welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. Today, we're thrilled to have Professor Konstanze Döhner joining us to discuss how to manage acute myeloid leukemia, AML, in young and fit patients. Welcome, Professor Döhner. Thank you for being with us today.
So first of all, I would like to thank EHA for the kind invitation to discuss with you today how to manage AML patients fit for intensive chemotherapy. I'm very happy to be here.
What are the essential steps in the diagnostic workup for young, fit AML patients?
So the essential steps for the diagnostic workup in young, fit AML patients starts with morphology. So by performing a bone marrow and a blood smear, followed by multicolor flow cytometry to determine the correct lineage assignment. And also flow is more and more used now to determine the leukemia associated immunophenotype for MRD monitoring in these AML patients. And then we still have cytogenetic analysis. This is still the gold standard for the diagnostic workup in AML, followed by molecular profiling. That means analyzing molecular markers, analyzing gene mutations to determine the genetic risk profile of the patients according to the European Leukemia Net recommendations.
Can you tell us how has the 2022 ALN risk stratification system changed our approach to young, fit AML patients?
So the updated European Leukemia Net recommendation that have been published in 2022 in Blood, they are not only an update, but they further refine AML genetic risk stratification. And there are two major changes that we can see in these updated ELN recommendations. So first of all patients harboring a FLT3 ITD mutation are now categorized into the intermediate risk group. And there are several reasons for that. So one reason is that it was really difficult to harmonize the assays, and by determining the FLT3 mutant to wild-type allelic ratio, there was a broad variation. Second, is that MRD monitoring plays an increasing role, in particular in patients harboring an NPM1 co-mutation. And third, we are now having very successful FLT3 inhibitors for the treatment of AML patients with FLT3 ITD mutations. Another very important change in the updated ELN recommendation is the introduction of a new category of a new gene signature that is defined by AML with myelodysplasia-related gene mutations. And these patients are now categorized into the high-risk group. And that means that a considerable proportion of patients with firmer intermediate risk are now categorized into high-risk group. And that means for us that these patients are now assigned to receive allogeneic stem cell transplantation.
Can you tell us what is the current standard for induction therapy in young, fit AML patients?
So the current standard therapy, this is the standard therapy for many, many years, is the so-called 3+7 schedule. And this consists of treatment with an anthracycline for 3 days and cytarabine for 7 days. I think this is still a very important backbone of intensive treatment in fit AML patients. There have been some modifications of this intensive chemotherapy because of the development of novel drugs. For example, we are now combining this intensive chemotherapy, the 3+7, with the available FLT3 inhibitors in FLT3 mutated patients. And we also have gemtuzumab, osagamycin, an antibody drug conjugate that is in particular effective in the CD33 positive AML patients. That means in patients with core binding factor leukemias, but also in patients with NPM1 mutations and other patients of the intermediate risk group. And finally, we have CPX351, which is a liposomal formulation of an anthracycline of daunorubicin and cytarabine, and that has been approved for the treatment of AML with myelodysplasia-related changes and therapy-related AML.
How do you integrate targeted therapies such as FLT3 inhibitors into intensive chemotherapy regimens?
It is our current standard to combine intensive chemotherapy with the available FLT3 inhibitors in patients with FLT3 mutations. And this is mainly based on the so-called RATIFY study that has been performed more than 10 years ago. At the ASH meeting this year, there is a 10-year follow-up of this RATIFY study showing very interesting data. And in the RATIFY trial, the FLT3 inhibitor midostaurin, the first generation FLT3 inhibitor, was evaluated in combination with intensive chemotherapy in FLT3 mutated patients. And this opens the era to precision medicine in AML. And based on the very positive results of this RATIFY trial, midostaurin was approved by FDA and EMA in 2017 for the treatment of FLT3 mutated AML patients in combination with intensive chemotherapy. We also have second generation FLT3 inhibitors, and recently last year quizartinib was approved for the treatment of AML patients with a FLT3 ITD mutation in combination with intensive chemotherapy. And we also have other very interesting novel drugs in the clinical development, like, for example, the combination of intensive chemotherapy with IDH inhibitors in patients with IDH1 or IDH2 mutated AML. We now have the menin inhibitors in clinical trials investigating the effect of the addition of these menin inhibitors with intensive chemotherapy. And we also have trials evaluating the combination of intensive chemotherapy with the BCL2 inhibitor, venetoclax. However, these trials are still ongoing and we have to await for the results.
And when do you recommend allogeneic stem cell transplantation for young AML patients?
The recommendation to perform an allogeneic stem cell transplantation is depending on the risk-benefit ratio, and that is based on the cytogenetic, on the molecular risk of the individual patient. For sure, this is also depending on the patient's wish, on the donor availability, the type of donor, and on many other factors like comorbidities. But in principle, I think one has to recommend allogeneic stem cell transplantation in patients having a higher probability to relapse. And for us, a higher probability means a risk of more than 35 to 40% of relapse. And in these cases, we do recommend allogeneic stem cell transplantation. And in practice, that means that all patients having an adverse risk and genetically adverse risk, we are recommending allogeneic stem cell transplantation. And also for intermediate risk patients, we are now recommending allogeneic stem cell transplantation in first complete remission.
How does MRD, measurable residual disease, monitoring influence treatment decisions in young AML patients?
So this is a very important and rapidly developing field. The MRD status is very important for treatment decision making, in particular for the type of post-remission therapy. And that means if a patient should receive allogeneic stem cell transplantation or not. So in recent years, we have seen a large number of studies clearly showing that the MRD status at defined time points during the treatment and after the treatment, that means during the follow-up period, is of prognostic relevance. And you can also use the MRD status to identify an early molecular relapse at any time point, in particular also after allogeneic stem cell transplantation. And based on the MRD status, you can start preemptive therapy. So with regard to the molecular markers that are currently used for MRD monitoring, we have very, very solid data for using the NPM1 mutation and also gene fusions resulting from the core binding factor leukemias as molecular markers for MRD monitoring. And very recently, we also now have very solid data on MRD monitoring in FLT3 ITD mutated AML. And with regard to multicolor flow cytometry, using this technique for MRD monitoring, we also have very solid data that the MRD status based on flow after one, better after 2 cycles, is of prognostic relevance. However, I think it's important to mention that flow-based MRD monitoring is technically demanding and is restricted to really very experienced laboratories.
What are your thoughts on the potential of CAR T-cell therapy in AML, particularly regarding recent developments targeting CD123 and CLL1?
So in contrast to the lymphoid neoplasms, the development of CAR T-cell therapy or immunotherapy in AML is a major challenge. It still remains a major challenge. And this is depending on several factors. Just to mention, to find an appropriate target, and the fact that there is a lack of immunocompetent cells in these really active leukemias. So gemtusumab ozogamicin, this is an antibody drug conjugate against CD33, is the only immunotherapeutic target that has been approved for the treatment of AML. And with regard to the development of CAR T-cell therapies, there are currently some studies under investigation using several targets, such as the CD123, the CD33, the CLL1 or the FLT3, but the first results from this study are really more than disappointing. And I don't believe that any of these CAR T-cell therapies will become approved for the treatment of AML in the next 2 to 3 years.
Thank you very much, Professor Döhner, for this insightful conversation and for sharing your valuable expertise with us. Thank you to all of you for listening, and stay tuned for our next episodes.
Thank you.